Colleagues, it is time to resume our Finance Committee meeting. Now, for the second item on the agenda, it is FCR 2024-25-26. This item invites members to approve the creation of a commitment of $1,395,818,000 for building the eHealth Plus healthcare information infrastructure. The Health Bureau on the 20th of February 2024 consulted the views of our Health Services panel. To answer your questions, we have Mr. Sam Hui, Deputy Secretary for Health, Ms. Erica Lam, PAS for Health, Dr. Zhang Ai-cheng, Head of Information Technology and Health Informatics from the HA, Mr. Dixon Wong, Chief Systems Manager, and Mr. Eric Wong, also Chief Systems Manager. Three gentlemen from the HA to answer your questions. I'd like to defer to Ms. Rebecca Chen to report to you the deliberation of the panel. Thank you. At the meeting on the 20th of February 2024, the HASP received a briefing by the administration on the eHealth Plus 5-year plan. It is expected that $1.3958 billion would be needed in terms of a non-recurrent provision. Most members agree to refer this proposal to the FC. Well, in the light of the need to spend nearly $1.4 billion for the eHealth Plus, there are suggestions to break it up into a number of smaller projects, and members are also concerned about the system safety as well as the confidentiality of the data. Moreover, only 1% or less than 1% of the e-health records were contributed by the private sector. Members wondered how the administration can incentivize the higher rate of participation or mandate the uploading of such e-health records. Members also suggested that we should consolidate the e-health as well as the HA Go functions, and there should be a connection of the information concerning the TCM and the Western medicine. Members also wondered whether we could also tie in with the cross-boundary healthcare needs of our citizens in the Greater Bay Area so that data follows the patient. The administration answered our questions, queries, and suggestions. 14 members would like to ask questions in this order. Yang Wing-Kit, Benson Luke, Lam Chen-sheng, Dr. Su Chang-wing, Mr. Chen Kin-po, Chen Xiu-hong, Chen Wing-kwong, Chen Hoi-yen, Tan Ka-piu, Duncan Chiu, Kenneth Lau, Kingsley Wong, Dr. Chow Man-kwong, and Shang Hai-long. Well, in the light of this number of members asking questions, there is a chance that we can complete our deliberation. Depending on the development, if there are more members wishing to ask questions, then I will decide on whether we can complete the discussion and put the matter to the vote. First of all, Mr. Yang Ming-kit. Thank you, Chair. I would like to thank the Bureau for having a close liaison with us in relation to the e-health system. We are grateful to them for being so responsive to our suggestions. In relation to e-health manager and e-health tracker, well, we know that e-devices are very popular. We may have our smartphone or we may have wearable devices to measure our blood pressure, our heartbeat. So we can be watching our health data all the time. I know such functions are to be covered by the eHealth Plus. Yes, you have my support in this regard, but still, I think you need to answer our other questions. $1.4 billion is no small sum. It is a major infrastructure. You have my support, but still you need to consider the following. Try to make some savings. Say, for example, I've been saying that now you have the e-booking. What about the HA Go function, which has got a similar function? After you've got eHealth Plus, what about HA Go? Does it mean that we can dispense with HA Go? Because quite a large number of records and a lot of the appointment functions are quite similar, very similar to those of the HA Go. So I would suggest that you only need to include what is absent from the HA Go. That would make savings, and it would also save us manpower. By consolidating the two, then we don't have to spend money on HA Go, and citizens don't need to go to two different applications. Now 6 million have registered and 3.4 downloads, but then only 220,000 monthly views. Probably more of them are elderly people. For elderly people, if they want to see the doctor, they have to use the application so as to use the elderly care health vouchers. Well, I think you are going to create a new application. Do you have resources to promote the fresh download of this application, or would it be simply updating the existing e-health application? Probably it is not, but I don't see resources being set aside for this purpose. And then I'm grateful to you in the sense that for eHealth Plus to succeed, you need to count on the private healthcare clinics to upload the health records of their patients. You did mention that there is a possibility that it will be mandatory. It is good. It can increase the utilization rate. But do you have other support measures? Do you have consultants to tell you or to tell us which systems would be suitable? And do you have resources to support the private healthcare providers? 3 questions, in fact. Let me answer the second question first. For eHealth Plus 5-year plan, we are going to have new functions added to the e-health system. In the course of it, we would like to make it very convenient for our citizens. As Mr. Yang has rightly pointed out, we don't need the citizens to download a fresh e-health system. In fact, we're building on the existing e-health system. Anybody who has registered and who has downloaded the eHealth application, it is merely a matter of updating or upgrading it. So for those who have already been using eHealth, they would have spotted new eHealth Plus functions, which are sort of functional already. So just want to take this opportunity to say that in the middle of this year, we are going to introduce a new function so as to facilitate cross-boundary downloading of e-health records, so as to facilitate cross-boundary treatment at a medical facility. So citizens don't have to download a new application afresh. Just now, Mr. Yang talked about the eHealth Plus and its relationship with HA Go. Well, in fact, we did spend a lot of time to sort this out. Well, e-health system is an integrated system. In other words, it spans across the public and the private sectors, covering hospitals, clinics, and other settings like the primary healthcare providers' services. In other words, the coverage is much larger than that of HAGO, which only covers the services of our public hospitals. In other words, when we try to consolidate the functions, what we aim at is as follows. Whatever that can be done on e-health, we hope that it won't be sort of repeated elsewhere. For indispensable and more locally related functions which are not amenable to directly available on the eHealth Plus, then we will have a seamless connection or seamless link on eHealth Plus so that people can make use of one single interface to go to the other function, like the appointment function mentioned by Mr. Yang. Other than the public healthcare system, many other healthcare organizations and private healthcare providers, they have their own appointment systems. We can have that sort of consolidated. And then for private doctors and private clinics, and what sort of support are we rendering them? We do assert a lot of efforts. We have the pilot schemes so that they can be connected to our system. That has been done at the backstage, and we have also been helping private doctors to get connected. Well, in fact, such work is covered in this 5-year plan, and the money asked for would cover that as well. Thank you. Next, Mr. Benson Luke. Thank you, Chair. I speak in support of the transformation from eHealth to eHealth Plus, $1.3 billion will be needed. Now, if we are to average it out among the 7 million people, in other words, it would only be a mere $200 per head. In other words, it is worth the money, it is value for money. But let me go to paragraph 9. Well, during the pandemic, the number of people registering eHealth reached 6 million. In other words, 80% of the total population in Hong Kong. Registration is but the first step, and for those who have downloaded the application, we hope that they can use it and they will use it day in, day out. That's the more important issue. For eHealth Plus, it isn't just more facilitating our appointment and other issues in the care journey. For the 6 million people who have downloaded the application, I think it should become the place where they're reminded to pay more attention to their health. For the first 7 functions among the 9 core functions, there's more about medical care, and we have eHealth Life to encourage people to lead a more healthy lifestyle. Paragraph 39 mentions that it is hoped that through the eHealth Life we can sort of encourage people to do more exercises. But unfortunately, if you rely on this method alone, I think it is more like for the sake of fun rather than for other things. Well, in fact, we have got all sorts of applications of a similar nature by recording your steps, by recording the time that you run. Sometimes it can be converted into some rewards or awards. So this is a very good application, and 6 million people have already registered. I think just like in the case of the Green Sense, maybe by clocking a certain number of steps, we can gain rewards that we can use, say, on the MTR. So other than encouraging them to use it for their healthcare needs, I think we should also use this opportunity to encourage them to lead a more healthy lifestyle. Secretary, the member mentioned the eHealth Life functions. I think Mr. Luke has shared with us very good observations. For the first step, we'll work through the schools, and then parents, mothers, and students can play games on the application. They can use the eHealth Life platform to take up a more healthy lifestyle. But then it isn't just for the sake of promotion. At the same time, we hope that the eHealth Life will be a platform that people will be using all the time. In other words, what it means is that, say, for example, as mentioned by Mr. Luke, we have already planned for that. That is, we can have something like a award scheme. Other than working through the eHealth Plus platform, as the member has said, in the community, we have got many wearable devices, and they have their own systems, and we have got incentive. They can collect the health data. So, as to how we can sort of connect with the health data collected on the devices in the community, that's a question. For data captured by the wearable devices, we hope they can be seamlessly uploaded onto the eHealth Plus platform, and then users can manage their healthcare data on a single platform, and it will be conducive to a better health. Next, Mr. Lam Chun Sing. Paragraph 11 mentions that almost all the eHealth records were contributed by the public sector. In other words, the HA as well as the DFH, 99% in fact, only a very small number of the records were contributed by the private sector. Now, for the private HCPs, the contribution rate is really on the low side. Now, the secretary has said that they have put in more efforts, but I'm afraid the outcome is still unsatisfactory. I think for the eHealth Plus, I think having the eHealth records would be most important. We hope that the doctors can understand the health status of the patients better, and that can facilitate better treatment outcome. If most of the records are from the public sector, then it is merely like a part of the HA goal. Now you're going to spend $1.4 billion on that. Would you agree with me that it isn't really that effective? I think you have your own health records in relation to the HA patients. So I think what is best is that private sector would also contribute the data so that all doctors can have more information to rely upon. So do you have a clear objective that is within a certain period of time, the uploading rate in particular that contributed by the private sector will be increased? You talk about amending the law. One consideration being mandating the important health data of patients to be deposited with the eHealth Plus account. So what is your initial idea? What do you have in mind as to the important health data? If upon amending the law, it is found that the contribution rate from the private sector is still on the low side, would you say that the eHealth Plus effectiveness would be undermined? And then for the annual recurrent expenditure, it would cost $110 million. I think that's for the sake of maintenance, etc. So please explain why you will still need more than $100 million for maintenance and repair. Are you saying that you need to recruit a large number of IT personnel to take care of maintenance, etc.? Or you don't need to have new civil servants and you can count on the existing staff members of the HA as well as the DFH so that the maintenance fees don't have to be on the high side?
So two questions. First, the participation by the private sector, and the second question is on the recurring expenditure. Deputy Secretary. Thank you, Chairman. For the first question, I will take that. I will defer to my colleague for the second question. Mr. Lam has touched upon the contribution of data from the private sector. One of our important tasks, as you can see from the paper, is that we will try to prioritize the programs and also the targets that we want to achieve. So for the first 2 years, we hope that for the preparation of the system, we will be able to cover all the private healthcare providers, and the system will be ready. So that means for the first 2 years of this 5-year program, we will be able to include all the private HCPs technically. That means they all will be technically able to input data. For the progress, we are doing well. And by the middle of this year, we have also rolled out a scheme for the private sector. And within a few months, we have able to include 400 doctors in the system. And we have about uploading about 400,000 e-records. So during the participation by the private sector, they think that we have given them good technical support, and it will not give them extra work in terms of the day-to-day running of the clinic. So for the first 2 years of the 5-year program, we attach a lot of priority and importance to this. For the second question, I would defer to my colleague on the recurring expenditure. The speaker is not coming through. For the $110 billion, it is about 7 to 8% annually with regard to the project cost. For such a large-scale system, this is a low recurring cost. Within the $110 million, about 25% will be used for software and hardware, because this is a very large digital infrastructure project, and every year we have to regularly maintain the hardware and the software. And also we have a system maintenance that is required, and also professional support services. We need certain manpower to undertake such work, and the cost is about $76,000 a year, $76 million a year. So this is also not on the high side. Thank you. Next, Mr. So Chang-Wing. Dr. So. Thank you, Chairman. I think smart healthcare is the trend. We hope that the doctors and the citizens can save time because of this program. And also it will bring a lot of convenience. It will be a one-stop service. We can manage and share medical data. And then also medical services will be more precise and convenient. So I support this proposal. Turning to paragraph 48 of the paper, there is an implementation plan and also a timetable. I have 2 questions. First, on the One Digital One Health data repository, it will only be available by the year 2029. That means the last year of the 5-year program. For the other components, you are saying that it can be rolled out from 2024-25 gradually in phases. So the One Health data repository is very important. It is a platform for data sharing. And then also the e-health digital platform infrastructure is similarly important. So if they are not ready until the end of the program, how can you ensure the other components will be delivered well? Because the data is not ready. This is the first question. Secondly, I think you have worked hard on the implementation timetable. You will require 5 years' time. Is it possible to compress the program so that the whole system will be put into place earlier? So 2 questions. First, about the data repository and the digital platform. Second, on the compression of the timetable. Thank you, Chairman. For the One Health data repository, we want to explain a bit more about that. You may be aware that for e-health, we already have a e-record database. Before we roll out the e-health plus, the current system is already being used by the public and the private medical sector for the moment. So there is already a database to facilitate the caring of our patients at the moment. So with the rollout of the e-health plus program, this database will be enhanced. And there is an item called the One Health data repository. What we meant here is that it is not a personalized e-health record for citizens, because for the citizens, it the data will only be read by the doctors when they go see the doctor. But for the data repository, it facilitates the medical development research and analysis. If we have such a comprehensive database, we can try to have synonymous data and try to encourage the development of medical innovations and research. It will also facilitate the government in mapping out public health care policy, and we can make use of the big data, and it will be conducive to our medical policies and issues. So we take time to develop this. For the e-health record sharing ordinance, we have already put in some legislative provisions governing the data collected by the e-health. And we also look into how these data can be used for analysis and research purpose or statistical purpose. But these provisions have not come into force yet because we have to wait until the system is ready. Then we will make use of these provisions and we will open up the system for non-direct medical use. So there is a sequence here that we need to follow. To respond to Dr. So's second question on compressing the timetable, we actually have been taking a measure, as you stated in the paper, that for the major projects, we have broken down into about 40 items. And we actually have about 160 work items in total. So we will roll out the items individually as and when they are ready through the eHealth Plus for use by the HCP or by the citizens. We won't wait until the end of the 5-year program to roll out the components. So before funding is approved, we have already been undertaking preparatory work this year. So we may be rolling out some of the functions this year. So we want to try to roll out the useful functions as and when they are ready for use by our citizens. Thank you. Mr. Chan Kin Po. Thank you, Chairman. I support the funding proposal. A lot of industries have been digitized. This is a very important system for Hong Kong and should be digitized. I think in Hong Kong, we need digital information sharing system for the medical staff to look at their records and also for citizens to look at their own records. On page 10 of the timetable, most of the items will be commenced by 24-25. There are 23 of them. I think this is a very pressing item. I think to enhance security is very important, but it will only be available by 28-29. So for this important item, is it possible to advance it? This is the first question. Second question, some colleagues have pointed out that for HA Go, will it be integrated with the eHealth Plus? Is the ultimate goal to absorb the HA Go within the eHealth Plus? So the first question is about timetable. We have touched upon that earlier, but for the eHealth Plus and the HA Go, we have also talked about the two platforms. Deputy Secretary, anything to supplement? Let me elaborate, Chairman. Mr. Chan has talked about the improved operational efficacy, security, and data privacy protection. On the timing, it will be running from 2024-25 to 28-29. That doesn't mean that the project will be completed by 28-29. We have a timeline spreading across the 5-year period. But as I just said, even before 24-25, we've been working on the item because this is not a new system. We are trying to build on the existing system. So as and when we include new functions, there will be new users, there will be new interfaces. Some platforms will be connected to it. So we have to spend time to look at the interface, and we have to work on the efficacy, security, and data protection. So this is a continuous work. It doesn't mean that we only will do so by the end of the 5-year program period. So I would like to explain that. For eHealth Plus and HA Go, the integration of the two systems, we have touched upon that. At the moment, there may be some duplication for the functions, but we will try to streamline that in future. So the citizens will notice that in future, the function will be undertaken by the eHealth Plus. But for certain functions, we may have to retain them in other systems, for example, like the HA Go. One example is that if you try to make a booking appointment or manage your medicine, so if you look at the eHealth Plus system, you can look at the information about the private and the public HCPs. But I think a lot of you have gone to the public hospital. If you try to go to the pharmacy, you will need an interface from the HA Go, which tells you what is your queuing number and how long you have to be waiting. So these functions will be connected with the internal operation of the HA. So these may not be suitable to be incorporated into the eHealth Plus. So we will try to have a good division of work between the two, but I don't preclude that some of the functions will need to be remained in the HA Go app. Thank you, Chairman. Next, Mr. Chen Siu-hong. Thank you, Chairman. I support the proposal to establish the eHealth information infrastructure so as to promote digital healthcare system in Hong Kong. I hope that through the establishment of the eHealth Plus, we'll be able to make use of big data to enhance the efficiency of medical services. We have an exchange with the organization C15 Plus, and we have got the answers from quite a number of questions. So now I would only like to focus on the financial questions. The first question is on page 18 of the paper. It is stated that the administration will make use of secure cloud service. So I want to know whether the eHealth Plus will make use of the cloud service of the OGO, or it will make use of other cloud services. If it is the latter, I will be worried that it will be costly and there will be safety issues. Second question, in Annex 5 on the cost-benefit analysis, there is a recurrent expenditure for 5 years, about $17 million. So I would like to know which staff are we talking about here? If it is for development, then they should be included in the development team by HA. So are we approving the funding of 1.395 billion, or we have to approve a bit more, including the figure that I mentioned above? For Annex 4, if we don't look at the contingencies, it is about $1.269 billion. But if we include the two funds together, two amounts together, it will be about 86% of the total project cost. I try to compare this with similar IT projects undertaken by the government. Usually, this figure accounts for about 60 to 70%. But now here we're talking about 86% for this particular project. So is it on the high side? And then also, the eHealth Plus is being built upon the existing system, the eHealth. The last question on para 54 for the recurrent expenditure, $110 million. Some member has asked about that, but I have to ask a question from a different angle. It accounts for about 7 to 8% of the project cost. This is not unreasonable, but about 90% of the cost is on the covering hardware and software maintenance. And the cost would be from 2029 to 30. But for the coming 5 years, some of the items will be rolled out gradually. So from 2026, some of them will come into operation. So the hardware and software maintenance should start earlier then. So why does the cost only incur by year 2029-30? So these are the questions that I want to raise. So I think questions on 4 aspects. Deputy Secretary. I would defer to my colleague, Mr. Dixon Wong. But before that, I want to respond to 2 points. First, for the eHealth Plus, the 5-year program, a lot of the work concerns the development of different functions. And also, we are working on the system interface with different HCPs and the individual citizens. So these are more on the operation aspect. So for the hardware and the software development stage, the maintenance period for them will be different. So this is one of the reasons for it. Secondly, on paragraph 54 of the paper, we talk about the recurrent expenditure. This is a reference for members, and it is not part of the funding proposal we submitted to you today. So when we try to develop the system for these 5 years, the maintenance of the systems, as Mr. Wong has talked about the license fees for the hardware and softwares, they will be included in the funding proposal. I would defer to Mr. Wong for the details. Mr. Dixon Wong. Chairman, on the first question about the cloud service, for the eHealth Plus, we would try to make use of the stage 1 and stage 2 structure, which is in existing, and we will try to build in a modernized cloud service. So this is a private cloud. For members have pointed out there are security issues. For the design of the eHealth system, for the design of the core system, we have built-in protection for data security and then also cybersecurity. For the ecosystem, we will try to modernize it, and we will try to increase new technologies to enhance system security. So this system has been in place since 2016, and we have been attacked from time to time, and we have been able to stop them. So for the future, we will try to step up our security measures. On the cost effectiveness for the staff costs, there is a $170 million. You can see that this is a small amount. It is mainly for staff of the Health Bureau, and they will participate in the schemes. So the staff costs will be included, but they are existing staff, and we have not included new headcounts. It is only for the purpose of the calculation of the value for money we include them, and they have not been included in the total project cost of $1.4 billion. For the recurring expenditure, there is a question about the hardware and software maintenance. The cost seems to be high. As I have pointed out earlier, for the eHealth Plus system, we are trying to build it on top of the stage 1 and stage 2 of eHealth. For the stage 2, it was because of the COVID situation in 2022. We have a large-scale enhancement so as to meet the applications and functions needed for the COVID epidemic. So we will continue to enhance the system and to modernize it so as to meet the development for the coming 5 years. So we are also making use of the existing structure and system.
We're way past the time limit. I will stop you here because we have many members waiting to speak. Professor Chen Wing-Kwong. I first would like to declare I am one of the committees promoting digital development of the HA, and my clinic also has registered for eHealth. To promote quality health services, I would support the proposal. But this would cost $1.4 billion. It is not a small figure. As you may remember, last week we have passed 2 projects relating to digital infrastructure. One of them is for the police's 3rd generation system. It would cost approximately $140 million. It would set up a digital central platform, and that would cost $38.5 million. And last year we have already had funding amounting to $190 million. Why does it cost 1.4 billion for the Health Bureau, which is significantly deviating from the other digital infrastructure projects figures? I also want to ask about paragraph 23. So it is said that it would cost over $460 million for staff costs, but then it would also cost much for the sourcing of consultant services. So I want to ask how many staff members of HA will be involved? Why is it that you, with an in-house development team, you would still have to spend $600 million on intermediary services? We have all along been trying to break the digital barrier so that Chinese medicine practitioners will make use of e-health. Every time I ask about this, the Secretary for Health would say that the take-up rate of Chinese medicine clinics is so low that we should consider doing that first. And in fact, it is said it is only in 28-29 that there would be support for Chinese medicine practitioners and clinics to access records set out by the Western medicine clinics or hospitals. I do not agree with the stance that the Secretary has been taking, because I think it's a chicken and egg problem. It is because Chinese medical practitioners cannot access the relevant records that they are not motivated to register. And as for whether we can have Chinese medicine practitioners, we should not consider the take-up rate. We should make sure we should promote the use of such system for healthcare practitioners to have access to records of patients in order to ensure the welfare of patients. So I ask, for the interest of patients, the Bureau should allow Chinese medicine practitioners to access health records of Western medicine practitioners. Well, the member has asked 3 questions. The first question has already been answered. The second question relates to the procurement of services. The third would relate to the access of records by Chinese medical practitioners. Will you support the use of the system by Chinese medicine practitioners? Thank you, Deputy Secretary. Thank you. E-health, compared to other systems that have more singular functions, is different because it is not simply a database. It is not some form of system that is only allowing access of information. Of course, the system is supported by data, but there are many different functions used by many different users. It is an integrated system. That's why the development cost is higher compared to other public digital infrastructure projects. It is hard to draw a comparison with other projects. But for example, we often quote examples from Singapore in terms of digital healthcare infrastructure. It has comparable infrastructure in the past 8 to 10 years. From what we know, They have spent approximately $4 billion on the development costs of their healthcare digital infrastructure. And from then until now, we have spent approximately $1.1 billion. So with what we have here, it would amount to approximately $2.6 billion. But I am confident that the functions offered by eHealth Plus would be even better than those of Singapore. Regarding the establishment for the development team, we expect that in the HA, they will engage approximately 60 staff members for the development of eHealth Plus. As you may be able to imagine, for eHealth Plus, we have over 160 projects. A 60-person team would not be adequate. But as I said, it would be built on top of the eHealth system. It would feature enhancements in functions, security, and so on. And we would need the core team to play a gatekeeper role. For specific functions, if we can procure from the market, we do not wish to start from scratch to save some manpower costs. That's why in the development team, apart from that, we would also have some cost for system maintenance and professional support services. We would work with private operators. Through such collaboration, we can take forward our work better. The third point is that we have the same goal as Professor Chen. We want to help patients with eHealth Plus. And in the process, Chinese medicine practitioners play a significant role. Professor Chen, please rest assured, with the planning of use by Chinese medicine practitioners, we would make sure that the system would be useful to Chinese medicine practitioners, but we need the relevant experience in order to make such a system to be of good use to CMPs. So we would ask CMPs to get more involved in this. That would definitely be beneficial. So I ask Professor Chen and other CMPs to help us break the digital barrier, and we can perhaps take forward such work more expeditiously. Thank you. Ms. Chen Hoyan. Thank you. We have different directions with eHealth Plus, and you are to set up a one-stop platform for that. There's really no reason why I would object to the proposal. But with the handling of the Health Bureau, I have reservations. For HA Go, it was launched on 12th of December 2019, and eHealth infrastructure was launched in 2009. And in March 2016, it was already promoted in both the public and private sectors. It has been multiple years. That is, in 2016, you were already promoting the use of eHealth, and then it was only after that, in 2019, that you launched the app for HA Go. Was that even necessary? You can see in many hospitals, they are still promoting the use of HA Go, and in future, HA Go's functions, certain functions will all still be retained, such as to book appointments and to wait lists for appointments. So HA Go will still be in operation in future. I want to ask how many projects of eHealth Plus will be overlapping with the functions of HA Go. In 2019, HA Go was launched. It has now been 5 years. Is it the case that in the next 5 years you will not have any other new platforms? Will you have Department of Health Plus or some Leave Home Safe 2.0, 3.0? We won't have anything on top of eHealth Plus, right? I want to make sure with a cost of 1.4 billion, we won't be developing other new platforms that can have overlapping functions. I also agree with what Professor Chen said. We will soon have the Chinese Medicine Hospital. If eHealth Plus blocks out the CMPs with a cost of $1.4 billion, it is definitely not acceptable. I can see many CMPs that are very eager to participate, and I have seen some university students who have already been using Chinese medicine records. Is it the case that eHealth Plus, with the cost of $1.4 billion, would not allow cross-access of records by Chinese medicine practitioners? I have already talked about some of the details, but I can give more historical information about HA Go. HA Go was an app to help with its clinical operations. Since its launch, it was never positioned to be something like eHealth Plus to serve the public. But of course, for certain functions, they have essentially piloted the use of certain functions for us to see if such functions are feasible. Such experience has been very useful in our developing of eHealth Plus. In fact, many on the team to develop eHealth Plus have worked on HA Go. So the experience is definitely beneficial. With that said, I would say in future the development of eHealth Plus would be the development of a platform with the other apps, HA Go and so on. We would make sure there is no overlap of functions. If there are indeed overlapping functions, unless the function is irreplaceable, we will remove such functions. We will have it incorporated in eHealth Plus. The direction that we are going to take with eHealth Plus and HA Go is that actually in the past 2 or 3 years, we have already been rationalizing digital systems of the Department of Health. In our plans, we would not allow for anything on top of eHealth Plus, such as eHealth Plus Plus or any other interfaces. We would include everything in eHealth Plus. So for other schemes of the public healthcare system, for example, the chronic disease co-care program or the other outpatient services offered by the Department of Health, they will all have their functions provided under eHealth Plus. Let me say again regarding Professor Chen's point. In our 5-year program, we have provided for connectivity with Chinese medicine practitioners. We would also allow CMPs to access the records. We would deal with any existing or inherent problems with the access of records of Western medicine by CMPs. We would iron out such issues, and we have included the provision in our budget. We have already started collaborating with CMPs. In the Chinese medicine hospital, we already have a system that would integrate both Chinese and Western medicine records, and we have provided for in the system interfacing with eHealth Plus. So this is the direction that we'll take. But for the specifics, how will CMPs use such data to help patients? What kind of records they will upload? It is not exactly relevant to the operations of the digital system. It may be more about collaboration on a professional level. So I would again encourage Professor Chen to work with the sector to devise a better proposal. Deputy Secretary, I would say this. I would hope that you can provide briefer responses because you have gone much past the time limit. We have approximately 19 other members who are going to speak. There is really no way that we can put the item to vote today. I will have 6 to 7 other members speak, and then I'll end the discussion of the item here. Thank you. Mr. Chen Kapu. Thank you, Chair. The visions of eHealth Plus are very ideal. It paints a good picture of working with the other cities of the Greater Bay Area. With a significant cost of $1.4 billion, people would have high expectations. My mother and I actually visited the Hong Kong U Shenzhen Hospital recently, and within a very short amount of time, we were able to get a physical copy of the radiological image, and immediately in our online account, the radiological image was uploaded, and today I still have the image. I believe the Hong Kong U Shenzhen Hospital did not spend $1.4 billion on their system. So how can you make sure public hospitals, private hospitals, and other healthcare institutions in the Greater Bay Area can do something similar that would allow for immediate access online by users of health records? And in the community, HA Go is often called Ha Go. Elderly persons make good use of the app because they think it is convenient to make bookings or appointments through the app. I think there is really no replacement of HA Go. I think the HA has been promoting teleconsultation services through HA Go as well. eHealth Plus, would it be able to provide teleconsultation services, or would it be left to the HA Go to do that? Also, with nowadays, often people would have obesity problems. They would be prioritized in the handling of the department. We, of course, want to issue warnings in advance, but are we only issuing warnings, or are we going to actually reach out to the younger people? I only have one more question. I'll be brief. In the fourth enclosure for the breakdown, it says that you would spend $190 million to liaise with stakeholders for engagement. Why is it such a high cost that is associated with it?
Secretary, I'll be brief, Chairman. In relation to the systems of individual mainland hospitals, they are rather advanced. But then It is in relation to individual hospitals, but then among hospitals or in relation to clinics, I think our system is much better than that on the mainland. But then, of course, we do have this vision. That is, we are spending money on this public infrastructure. As Mr. Tang has said, we would like to have interface between the public and the private sectors in relation to the e-health records so that they can be shared and viewed and used. I think that's the core objective and core element of our system. We hope that in 5 years' time we can show you our outcome. As to the question of integrating with HA Go, there was already a discussion. Just now the member talked about the possibility of telehealth. Well, for eHealth Plus, we do have such included in our design. In other words, we want to have something which can suit the purposes of the public and private sector, as well as cross-professional users. We hope that we can have such a platform, an electronic platform. When that is completed, as I've mentioned earlier, then there will be no more duplication. So for the eHealth Plus platform, when this element is ready, it will become the officially authorized platform for telehealth and professional consultation. For eHealth Live, there is a vision behind that element. It doesn't mean that it is merely there for people to have their daily health data recorded. Through the eHealth Live, we hope that we can drive the public health education currently under the DFH. So if you're concerned about mental health, in fact, through eHealth Live, we can use it as a useful platform so that we can echo the services provided by the DFH as well as the primary healthcare schemes related to mental health. So what we want to do is that perhaps we'll start with encouraging doing more exercises. But later on, we'll also have other public health education topics. Thank you. Well, $190 million in relation to the engagement with the stakeholders, that hasn't been answered. No, it isn't just about communication or having conversation with them. Well, for the engagement, in fact, we may be talking about pilot schemes and we'll be providing technical support or even financial support before we can have engagement. So it is a matter of cooperation or partnership. Thank you. Next, Mr. Duncan Chiu. Let me declare interest. I'm a member of the HA. I'm also the chair of the Information Technology Panel. I speak in support of the funding request for the eHealth Plus. For an application to have 6 million people registered, this is unprecedented in Hong Kong. For you to upgrade this to become eHealth Plus, then I think for eHealth it's more on electronic, and for eHealth Plus it is more on health. I think you are trying to people have mixed up eHealth Plus and HA Go. Now we want to serve all the 7 million people. We want to cover all the health services needs of the 7 million population, and covering not just patients who are admitted to hospitals, but also healthy people who are not hospital patients. Just now a question was raised, and the Secretary also answered as to how eHealth Plus can be connected with many other existing applications. Well, we have got many applications that are related to health. We want to have health for everybody. I think between eHealth Plus and HA Go, I think for HA Go, I think the role is clear. When you become a patient of HA Go, then maybe sometimes you have to use their rehabilitation services. If you have two different bank accounts, then probably you need to install or download two different applications. So one is for big health, so to speak. Whether you're a patient or not, you will want to use eHealth Plus. And then for HA Go, you only need to use it if you are a client of the HA. Now, if we want to have health for everybody, then at the panel meeting, we said that adequate data would be essential. Private contribution is still limited for the time being. You have been publicizing and promoting it. Previously, sometimes clinics found it difficult to upload their records, and I think the problem has now been resolved. I think the DS has not answered the question concerning the 13 private hospitals. They are contributing 0.15% of the e-health records currently. And then what you have been talking about is more catered for the needs of the smaller clinics, but not so for the private hospitals. I think the previous term government also talked about whether we should have a law to mandate that. You have also said that you may want to empower the secretary to do so. And in paragraphs 46, 47, perhaps we should do more in relation to private hospitals so that we can gather more health data, so that we can really be talking about big health data. If we don't mandate the uploading of information by the private hospitals, and even if we have AI, etc., as a result of the lack of data, we may not be able to do much. So what about the case of private hospitals? Secretary. As to the legislative exercise that we have got in mind, that would be covered. That is, we hope by amending the law, we can empower our secretary to work by way of subsidiary legislation to specify what sort of data has to be uploaded by the private healthcare provider and have it deposited with the personal e-health account of the patients. We need to be ready on two counts. First of all, for the private healthcare providers, we hope we can help them to resolve their technical difficulties. In other words, we hope that they can have a technical solution for them to connect with our system and upload the information to our system. That's the first point. The second point is that when they get the sharing consent from the patients, they would not be subject to unnecessary restrictions. Sometimes what happens is that the private healthcare provider may have the data and the system is ready, but sometimes their patients haven't authorized them to deposit the e-health record. So we need to sort of amend the law so as to facilitate the healthcare providers to upload the records. When both legs are ready, then most of them, including the majority of the private hospitals, would be more than happy to upload the information. If upon amending the law, we still find that their response is poor, then we'll try to make use of other tools. Next, Mr. Kingsley Wong. Mr. Kingsley Wong. Thank you, Chair. We're going to spend a lot of money on this system. I support this because we are sort of going along with the trend of making use of technology. Useful and maximizing it are important. We have got specialist doctors and we want them to upload their patients' information onto the system. Well, it has been pointed out in the paper that there is a huge gap. The Secretary already answered this point. I don't need an answer from him anymore. My second question is about connectivity. For the Hong Kong U Shenzhen Hospital, more than 100,000 Hong Kong citizens went there to seek medical service. But then I do understand that you have got many hurdles to overcome, and you need to use a smartphone. Now, with the GBA development being sort of implemented and the integration is being deepened, can we have a through train of eHealth Plus? Say, for example, for the GBA is a bit different. We're integrated with the GBA. Can we not designate certain hospitals, and with the patient's authorization, we can allow GBA hospitals to have direct access to our healthcare records? Have you got this in mind? Would you allow that? I think what is of utmost importance is allow patients to have a choice and to facilitate the patients. So can you not designate certain GBA hospitals, and when we are sure that it is safe and secure, and with the patients giving authorization, allow that to happen? Secretary. Well, for Hong Kong U Shenzhen Hospital, we have the portable EHR function. To a certain extent, we are moving in the direction as mentioned by Mr. Kingsley Wong. In other words, the patient's smartphone can be relied upon to give authorization and to gain access. But then for the information to be transmitted at the level of the system, we have already done that with the Shenzhen. So it isn't just a matter of the patient getting the information on his own smartphone. In fact, what the patient is doing is to have a QR code so that the doctor can use the QR code to extract the health record of that patient from the system. So such a practice, such a workflow means that we can make good use of the available medical records or reports. But then we have to bear in mind one point. It isn't merely a question of technical connectivity. There are many differences between the mainland healthcare system and a local healthcare system. Their training may be different. How many of them would find it easy to use our records? And then for those who go to the mainland to receive medical services and the derivative reports, how many of them would be sort of be useful for our doctors here? We are moving in this direction, but then we may not be able to do that overnight. Well, we are promoting the GBA integration. Can we not sort of break down the restrictions so that the systems can be integrated? Do you plan to designate certain hospitals in the GBA so that they can use our eHealth Plus in the same way as our own hospitals in Hong Kong can access the eHealth Plus? Have you considered that? Well, we are thinking of expanding the scope and facilitating the convenient usage. But as I have said, it isn't just a matter of technical connectivity. There is a matter of professional collaboration and also the merging or integration of the rules and systems. Next, Dr. Chow Min Kwong. Chair. Whether it is good value for money in relation to the upgrading of the system, there are two factors. First of all, whether people are willing to download it and whether they would use it often, and whether the private healthcare records would be accessible and shared. Of course, it is voluntary and we have to consider the regulatory framework. But don't forget the patient's rights and interests. Would you consider amending the law so that the secretary would be empowered in case the response is poor? So empower the secretary to mandate eHealth records to be uploaded onto the system, in particular those from the private sector. And then every year you have to spend $110 million to maintain the eHealth Plus. I want to know how much is going towards cybersecurity. Now, of course, we're talking about the personal health records of our citizens. So how much of that money will go towards cybersecurity? And then 500,000 people are living in Kwangtung province. That's in the year 2020. I want to know, can those living in Kwangtung province benefit from the eHealth Plus? Secretary, I have already answered the question concerning mandating the uploading. When we amend the law, we will empower the Secretary for Health when it is necessary to specify which health records must be uploaded onto the personal eHealth Plus account of the citizens. Yes, we can empower the Secretary to do so, but we don't mandate citizens to use the healthcare, the eHealth Plus. Well, we hope that people see the benefits of eHealth Plus, and citizens are convinced that by having a comprehensive health record, it will be good for their health care, and then they will take the initiative to use eHealth Plus. That's the legal basis. But of course, we will do our utmost to convince everybody to use eHealth Plus so that they can take care of their health needs. As to the question of how much out of the $110 million are for the system security, I would defer to Mr. Wong. Roughly speaking, 10% will be for cybersecurity. I have to emphasize that when it comes to cybersecurity, it isn't just a matter of software and hardware, because eHealth Plus is an ecology, and we need to have attack drills, etc. And so that amount of money would cover such drills as well. 500,000 of people are residing in Guangdong province. Can they benefit from eHealth Plus? I think you know that we have cross-boundary usage of the EHCV, and we are promoting the use therein. In the middle of July, with the extension of EHCV to Shenzhen Hospital of Hong Kong U, eHealth will also be made available under such a scenario. Let's hope that by having collaboration with mainland hospitals and through government schemes, we hope that in future eHealth functions can be extended to other healthcare providers on the mainland. But of course, we have to be very cautious in terms of the pacing of this matter. As I have said, it isn't just a matter of technical connectivity. It is also a matter of the professionals using the data, using the healthcare records, and we need to have a sort of collaboration among the professionals. But then, of course, it is already a portable sort of platform, and will continue to develop in that direction.
Thank you. I think you would all note from the screen there are a lot of members on to speak. So following Ms. Chen Yutming and Ms. Connie Lam speak, we will try to close the session, so the other colleagues will speak at our next meeting next week. So from next Monday onwards, I will ask how many members would like to raise questions, and then I will draw a line there. Then it will be easier for us to decide how much time will be required for scrutinizing this proposal. Ms. Chen Yutming? Thank you, Chairman. I support the proposal to upgrade the e-health. It will benefit the medical sector and all the citizens in Hong Kong. Personally, I support that. From a user's point of view, I would like to raise two questions. First, I think there is room for improvement for the system in respect of the access of information. We cannot access the information about the day for being admitted and released from the hospital. I have the experience of being released from a hospital without a piece of paper. So I hope that for the system, you will be able to enhance it from the user's point of view. So you will be an electronic health record, and also you would have electronic documents for use by the insurance companies so that people can make claims easier. Also, I know that there will be a one-stop data platform. You now have millions of users, and people are concerned about the data protection. The paper has only briefly touched on the protection of data privacy, so I hope the administration will elaborate on this. So before and after the upgrade of the e-health system, what measures will be put in place to enhance security and data protection, and what measures will be used against the hackers' attack? So two questions, Deputy Secretary. Well, Chairman, so for the documents to be included in e-health Plus, does not only include the diagnosis note by the doctor. We will also have other documents concerning the procedures. But having listened to Ms. Chan's view, if there are a particular type of document which need to be uploaded or included, we will be happy to follow up. Especially for the development of the e-health Plus, we would like to include data, the types of data to be shared, and we want to enhance the scope of that. So we hope that there will be more HCP uploading information to it, and also we want them to have different and more types of documents to be uploaded. And for cybersecurity, I will defer to Mr. Dixon Wong. Chairman, I would like to explain that for the e-health Plus system, we attach a lot of importance to system security. So ever since 2019 or 2009, when the system is being developed, we have already have a security design. We have a blueprint for it. And today we are using the same blueprint, and we always put system security first. So what measures will be adopted? Actually, there are two major principles. The first one is a deep level protection. So we would have different levels of protection and prevention. We use different vendors and services so that if we are being attacked by hackers, we will have different levels of security measures against them. Even if one level has been attacked, we will have another level coming up that will be resisting the attack. Also, we have the principle of zero confidence. So that means we look at the issue from 360 degrees, and the hackers come from all directions. So internally, we will try to also put in measures about the leak of information from internally. And we also try to put in different security designs at even the internal system. Even if the hacker can come into the data set, they may be able only to access part of the data, but not all of it. So for the security, it is not a one-time job, and the prevention or the fight with hackers is a continuous job. And we have put a lot of emphasis on the continuous risk assessment, and we also try to have drills to see whether there are areas for improvement. So this is a continuous or a race against the hackers. So apart from looking at the system, we try to promote the concept for the whole industry. Next, Ms. Nixie Lam. Thank you, Chairman, and I would like to thank the administration for explaining the proposal to us. I have a question concerning the eHealth Plus in future. Well, first, we talk about eHealth, but is it really connected? Ms. Rebecca Chan has pointed out that a lot of people is using eHealth, but then we have to upgrade it. But how, in a way, connectable is it in future? I have a case which I have put forward to the administration about 2 months ago. So if the connectivity is not achieved, the case can be very worse. I have received a case whereby a mother has come to me. His child has passed away for 4 months, but she has received an SMS saying that she has to bring her child to the maternal care center for health check. So this is a really very sad case because the child has passed away, but you do not know about it, and you issue a message to the mother that she has to bring the child for health check. This is really sad. We are now talking about we have to use $1.395 billion for the project. And it seems that we're just trying to buy a hope here. We don't have any measures to ask the HCPs to upload the informations and to use them. And then it may be lack of connectivity. So in a way, we are just using $1.39 billion to buy a hope. If the HCPs do not use them, if the people don't use it, then this large amount of money will be wasted. You said that you will be using about $100 million for liaison with the stakeholders, but I'm afraid that the money may not be put to good use. I think the citizens, if they look at the figures, they will think that it is a very expensive project. Well, I'm also worried that you don't have a mechanism to see what will happen if the project cannot be taken forward, or if it can be taken forward. I think for a lot of issues in the community, we cannot just focus on the best case scenario. We have to think about other scenarios. We are now being asked to approve a funding proposal, but how are you going to guarantee that after the funding has been approved, the project will be delivered, and we're not just buying a false hope? Well, I would now extend the meeting until the Deputy Secretary has answered the question, because there's only 1 minute left for the end of the meeting. Thank you, Ms. Nixie Lam. We are also concerned about the project. We are using public money here, and we want to have concrete results and deliverables. And we want to deliver what we have planned. If we don't do it, we'll be letting the citizens down and we'll be failing our job. Ms. Lam, you have pointed out an example which we can learn from. The situation is that when we try to connect the different bases, we have a lot of data. At the same time, we are also trying to look at the data from the medical and the non-medical sector. For some of the data, it is being captured during the administration by the different departments. For example, the birth records and the death certificates, they cannot be dealt with automatically. So we have to try to look for connectivity. And we also need to look at, after the connection, there will not be misunderstanding arising from it, as the example pointed out by Ms. Nixie Lam. The good intention is to provide convenience, but we may have the unintended consequence of hurting our citizens a second time, and we don't want to have that. So that means, apart from the design of the system, we also have to liaise with the stakeholders and connect with them. Even within the government, we have different systems. At the technical level, we have to have good connection or interfaces for the various systems. So this is one of the crucial tasks within the 5-year plan. As I have said at the very beginning, we are very concerned about the success of the project. We are as concerned as you are, members. We are now just talking about the public sector system, But for the eHealth Plus, the development, if it has to be comprehensive, we have to capture information from both the public and the private sector. And we got to have a very comprehensive scope, because the philosophy for the development of the eHealth Plus is how we can make use of a digital platform to connect all the components within the care journey, and then also the different healthcare providers and the carers. So there are many different interfaces. So it's not just between the public and the private sector, not just the doctors and nurses or the pharmacists or other allied health agencies. We are also trying to cover, say, laboratories, testing centers, and they have to be included in the eHealth ecosystem. So we have to see how we can connect all the elements within the eHealth ecosystem. So that means that it is a very complicated project and there are many different components. If there is any gap or missing link, then the whole ecosystem will be incomplete and imperfect. So I hope that you will support the development of this ecosystem, because it is very important for our medical sector. Thank you. Chairman, the next meeting will be held on the 12th of July at 3:30 p.m. It is between the House Committee meeting and the Finance Committee meeting. There is another activity in between. Thank you for attending.